Madam, just a minute. They are doing.
Hello, good evening, everyone. So I'm Dr. Tejashree. I'll be moderating today's session, and I welcome you all to the second session of this very informative class series that we've started last week. I welcome Dr. Abha ma'am and thank her for this initiative that she's taken to educate us all and update us with the recent knowledge. It was a wonderful discussion last week, and we had discussed about the PCOS, and of course gonadotropin resistant PCOS was something which took up a very interesting discussion. And our current FNB fellow, Dr. Yukti, had posted a very nice paper regarding this. And this was really a very nice, initiative by her, and such information sharing is really welcome. And I would request all of you to come up with such article sharing so that we can share our knowledge and educate each other as well. There was a discussion regarding vaginal use of progenova for endometrial preparation, which we would like to highlight here, but somehow we couldn't find any reference which would be the evidence which would be strong enough for us to use it. Abha ma'am, most welcome, and I would like to first have your comment on this.
I also could not find anything. These were just patient queries on the internet where they were comparing vaginal progesterone with oral progenova. So it had no relevance. I could not find anything. I'm sorry.
Yeah, even in the product information, there was no advice on using it vaginally. So I would request, our participants, if anybody finds any reference to that, we would really like to know more
It
about
has
it.
to be in a good journal, in a
Yes.
journal which has some impact, not a journal which has very, very low impact on reproductive medicine. Anyways, that is a very important question because progenova is often not tolerated by some of our patients, and maybe if vaginal insertion
Will
could
help.
be
Yes.
proven, it would be a great thing. So we can start the next talk now.
Yes, ma'am.
Tejasvi?
First of all, I would really thank you to, take this time out and continue with the series, because Dr. Abha was really unwell since last 2 or 3 days. She's suffering from swine flu currently, and that is the reason we had to postpone yesterday's session as well. But this is what gives her energy, I think, teaching all of us and having, having this very, very wonderful discussions. Over to you, ma'am. Please, let's do the
Thank
session.
you. The safety of this internet saves you all from my swine flu. So I'm happy that I can talk across the screen with you and not transmit the infection to anyone. The topic for today is always, it is a very big query for all of us, IVF or surgery, especially if there is an endometrioma sitting in. And our ultrasounds are the most important source through which we see that there is an endometrioma, and the question starts coming in that should we do a surgery or we should go in for IVF straight. So whenever we say should IVF be the first approach for ovarian endometriosis and infertility, there is a need for a shared and informed decision with the patient. What do we need? We need two main sets of information which should be provided to the patient. One is a general set where we give general information of what endometriosis does and how it can be tackled. And another one is a personalized set which is specific to that patient. Now, when we talk about general set, it includes realistic information on the effectiveness of the two approaches. Like with surgery, also, we would say 25% live birth rate for surgery. I have given all the evidences below, and so all those who are studying and are interested in evidence can take down these references and open up the articles and read. IVF also has a 25% live birth rate per single IVF. I'm giving you very conservative values of the two, which is universal. I'm not giving for one single center which could be having a 40% live birth and another which could be having 15% live birth rate. Cost is again center dependent for IVF as well as surgery. Then in surgery, there is always risk of hemorrhage, organ injury, infection, and anesthesia complications. And there is definitely damage to ovarian reserve, which is very, very common. On the other hand, IVF has a risk of OHSS and multiple pregnancy, which has now been negated to a great extent by segmentation of IVF cycles. And endometrioma infection is another complication if IVF is done in presence of endometrioma, though it is very rare. Like damage to ovarian reserve is very common in surgery, but endometrioma infection is a rare complication which would happen with IVF. What is the personalized information which we need to give every patient? One is, in your case, whether IVF is better or surgery is better. This is how we would give a personalized information. If the patient has had previous surgery for endometriosis, this favors IVF. If there is bilaterality, that means risk of severe impairment of ovarian reserve after surgery, as risk of additional damage to a weak ovarian reserve could cause definitive exhaustion of all follicles, which means already endometrioma has reduced the ovarian reserve, and further risk of impairment would happen if there is bilaterality. Then if the woman is of older age, mainly if she is more than 36 and she already has a reduced ovarian reserve, and if there is another factor which indicates IVF like male factor or tubal block. What favors surgery? Well, dimension and ultrasound appearance of larger cyst and doubtful diagnosis. Now, what is larger? We'll come later to this. Concomitant severe pain if resistant to medical treatment. So, pain is one important factor where surgery has to be undertaken on the cost of ovarian reserve also. And another one is antral follicles away from vaginal wall. We've stimulated the patient and we found that to reach every follicle, we have to go through the cyst. And if we have to go through the cyst to aspirate every follicle, 2 or 3 punctures could well expose the patient to a infection, cyst infection, endometrioma infection, which is again a bad complication. So in such cases, surgery is better, and this has to be patient-centric. Does the patient have a large endometrioma? Do we have a doubt in diagnosis? Is there a lot of pain which is not responding to medical treatment? And are the antral follicles away from vaginal wall? That means it's a large cyst where we cannot go from the side of the cyst. All this favors surgery. Now we'll come to the specific risk of surgery and specific risk of IVF. Specific risk of surgery is negative impact on ovarian reserve and responsiveness to controlled ovarian stimulation. We all understand and we've all seen it in our day-to-day practice. Major complications in around 10% of cases when the endometrioma surgery is associated with removal of associated deep infiltrating endometriotic lesions. So whether it is necessary to remove the deep infiltrating endometriotic lesions to get better IVF result, I'll come to this later. But major complications happen if we try to do endometrioma surgery with removal of associated deep infiltrating endometriosis. Doing a endometrioma surgery alone is much safer. Recurrences after incomplete cystectomy, I wouldn't say cystectomy, but yes, incomplete cystectomy, recurrences are much faster. After aspiration, recurrence occurs in no time. And another thing which I want to draw your attention to, post-operative hormonal treatment is inappropriate since all hormones are contraceptive. And this is the time after surgery, whether it is complete or incomplete, the patient is most likely to get pregnant. And then incomplete endometriosis surgery that can lead to unnecessary and to repetitive surgeries. So these are specific risk of surgeries. What are the specific risk of IVF? The most important one, which we all read, is it's a low risk, but it is a risk of tubo-ovarian abscess secondary to oocyte retrieval, especially if we've had to make many punctures to get the oocytes. There is a theoretical risk of disease progression, which was always there in our minds. But then when we read a lot about it, although rare cases have been reported, cohort studies have demonstrated that ART does not exacerbate symptoms, progressions, or recurrence of endometriosis. So this has been very relieving to read these articles that if we stimulate the ovaries, it will not increase the symptoms or the progression of the disease or recurrence of endometriosis. And negative impact, now we come to all perinatal implications of IVF, which is negative impact on health outcomes of the child. ART singletons are associated with a higher risk of adverse obstetric and perinatal complications. And we all know that in a naturally conceived pregnancy, if the a risk of congenital anomaly 0.9, then ART pregnancies have a risk of about 1.6, which is almost double. But then yet, I mean, it is a risk which one has to take, will take, because if that is the only way to get pregnant, then may it be. And multiple pregnancies generated by ART versus spontaneous conception are associated with higher risk of pregnancy-related complications and adverse pregnancy outcomes. And the only way to reduce the multiple pregnancy generated by ART is resorting to single embryo transfer, elective single embryo transfer, which I'm very glad that our center has been undertaken for the last 7 years now. 2017 when we started the single embryo transfer, and we are very happy with our results. But this only can happen if your lab gives you this much confidence that a single embryo transfer will give you a 50 to 60% implantation rate. With whatever losses you have during pregnancy, the live birth rate will still be 40%. Then only one can resort to a single embryo transfer. So IVF has sort of grown in leaps and bounds, and the risk of OHSS, the risk of multiple pregnancy have all been negated. But yes, ART singletons, when compared to naturally conceived singletons, are associated with higher risk of adverse obstetric and perinatal complications. But then there are many factors which are which sort of contribute to it. And we are not discussing that, but in general, this is what is understood. So before making a strategic decision, surgery or ART, it is paramount to evaluate ovarian reserve. ART outcomes are significantly reduced by previous history of surgery for endometrioma. ART should be carried out as the first intention in the following situations: decreased ovarian reserve, associated infertility factors like male tubal, endometrioma recurrence or previous history of surgery of endometriosis, and bilaterality of endometrioma. These are the four indications where IVF as the first mm, decision is very important. So it should be the first intention in these situations. Good outcomes with ART are not affected by the endometriosis phenotype. And this is what always troubled us, that is superficial peritoneal endometriosis reducing the chance of getting pregnant by IVF? And we always thought that 1 out of 10 cases by the EndoCan study, which was way back in the 2000, said that if you burn the superficial endometriosis, then when 1 out of 10 patients will conceive naturally. That is a far too fetched number, and superficial peritoneal endometriosis comes as unexplained endometriosis, and treating it or not treating it does not really affect the ART outcome. Same is with ovarian endometrioma and deep infiltrating endometriosis. This is very heartening to say that if there is deep infiltrating endometriosis, one does not need to remove it in order to get better IVF results. So you can go through this article 2017 ka hai ye, which will say that what are the prognostic factors for ART in women with endometriosis related infertility. All these three do not change the outcome of ART. Now, we all understand that endometrioma may on its own inflict damage on ovarian reserve, especially in cases of bilateral endometrioma. But yes, there is a reduction in ovarian reserve because of compression of follicles and the compression of the cortex of the ovary through expanding endometrioma. But the main damage is post-surgical. AMH concentrations fall by 40%. The operated ovary shows lower AFC, has lower number of mature follicles, and higher risk of having no oocyte collected compared to contralateral non-operated ovary. And I think we see this every day, that the operated ovary does not make a follicle at all, only one ovary responds, or ovary which has endometrioma will make less follicles, and the one which does not have an endometrioma will make more follicles. So in both ways, having endometrioma has its own damage, but having a post-surgical case, the endometrioma removed, we will find that ovary has much less, shows a much lower AFC and has very few mature follicles and oocyte collected from that. So we all understand that experience of a surgeon is one of the key drivers of success and low rate of complications. Even with very good operators, associated inflammation and compromised vascularization after extensive coagulation is unpreventable. The risk of post-surgical ovarian failure is 2% in expert hands also. And the cost is also to be considered. Now, here I would bring in one thing which I heard from one of my colleagues while she was attending a seminar on placenta previa and accreta, that suppose you have opened a case, a cesarean, to go ahead and you find that there are a lot of bluish discolorations and there is a chance that this is placenta percreta, close the patient and send her to a higher center. Same, I would say, if you put in a laparoscope and you find that this is a badly stuck case of big endometrioma or a large cyst, please do not start surgery on it. We've had bad cases, life-saving cases with severe peritonitis and septic outcomes in patients where incomplete surgery was done because everyone is not equipped with that type of surgical skill which is required by these cases. It is best to put in a scope, take it out, and tell the patient go to a center where they could do good surgery, and let the patient get the benefit of going through the best surgical procedure rather than proceeding with inadequate surgical procedures. Now, in the past, when any ovarian lesion was observed on ultrasound before ART, the gold standard was remove it in an effort to clean the ovary and get a better outcome af afterwards, regardless of patient symptoms. 15 years ago, only the whole thought process changed. A large retrospective study clearly showed that removing the endometrioma in women undergoing IVF did not improve cycle outcome. Conversely, operated patients required higher doses of gonadotropins, had lower E2 during ovarian stimulation, in addition to being exposed of the surgical risk of laparoscopy and its cost and prolong their time to pregnancy. So there has been an evolution in endometrioma management towards a much more conservative approach, acknowledged by the European Society of Human Reproduction and Embryology guidelines. The latest version of ESHRE guidelines clearly indicate that cystectomy in women with infertility wanting to undergo ART should be considered only to improve endometriosis associated pain or the accessibility of follicles. These guidelines also rightly recommend counseling the patient with endometrioma regarding the risk of reduced ovarian function after surgery and the possible loss of ovary. We have to be very honest to our patients and tell them, however well I do the surgery, but the ovarian function will reduce. Sometimes, in order to reduce or stop the bleeding, we might cause significant damage to the ovarian function. Previous versions still considered the size of endometriotic cyst as an indication for surgery, regardless of symptoms or any other issue. And for patients at risk of having their ovarian reserve severely compromised is when we need to offer them oocyte cryopreservation before surgery also. So these are the things which have changed in the recent evidence which has come up through ESHRE to us. These are the new guidelines, 2022, February, where they very clearly tell all the European Society clinicians are not recommended to routinely perform surgery prior to ART to improve live birth rates in women with ASRM stage 1 and 2 endometriosis, as the potential benefits are unclear. So if two IVFs fail, there is no point in going in with a laparoscope, looking for minimal endometriosis and trying to fulgurate it, thinking that this is reducing my IVF pregnancy rate. What is reducing your IVF pregnancy rate is some crosstalk between the egg and the sperm and the embryo formation and implantation. But this endometriosis has very little possibility to do in reducing the pregnancy rate. This is strongly recommended. Then clinicians are not recommended to routinely perform surgery for ovarian endometrioma prior to ART to improve live birth rates, as the current evidence shows no benefit and surgery is likely to have a negative impact on ovarian reserve. This is very strongly recommended again. So stage 1 and 2, not recommended. Stage 3 and 4, not recommended. Surgery for endometrioma prior to ART can be considered to improve endometriosis associated pain or accessibility of follicles. When you do ultrasound and you find that the endometrioma is towards the vaginal wall and some of the remaining ovarian stroma is distant to it, these are the cases. You can even stimulate one cycle and see, and you still find the same thing, that for every follicle you would have to go through endometrioma. It is best to stop there, remove the endometrioma, and then get to the cohort of follicles which is left behind. But this is a GPP. This is a practice point, a good practice point. The decision to offer surgical excision of deep endometriosis lesions prior to ART should be guided mainly by pain symptoms and patient's preference, as its effectiveness on reproductive outcome is uncertain due to lack of randomized studies. So again, this is a strong recommendation that you don't need to remove deep endometriosis before ART unless the patient has so much pain or he prefers that I want this removed, I cannot live with this pain. So it is bending so much towards IVF because of the risk associated with surgery, and the risk is more because everyone picks up a surgery for endometriomas, whether it is individual people or institutions, but it is the expertise of surgery which really counts. It is availability of resources which counts, and it is the conscious mind of ovarian reserve. And that is why I say that gynecologists, as good endoscopic surgeons, are better in doing these surgeries rather than surgeons, unless they have a gynecologist standing with them who is constantly harping, save the ovary, just remove the endometrioma, just shell off the cyst, please don't touch my ovary, please don't remove the ovary. So patients may be overwhelmed by the burden of contrasting information. So we have to remember that the decision is based on transparent and complete information, and freedom is required. Ability to take active role in decision making is emerging as a favorable outcome in healthcare in every field. The question cannot be reduced to simplistic approach of try surgery first. Physicians may be tempted to guide decision based on their own values and competencies, but this is viewed wrong. So a person who does mainly IVF will tend to try IVF first. Those who are surgically based centers will say try surgery first, because one, in today's world of competition, one wants to keep the patient with them. But if we are ethical and we are truthful to ourselves, then we need to know what does this patient need. Shortening time to pregnancy is preferred for most couples. Even if surgery and IVF had similar rates of success, infertile couples have preferences for a pregnancy that occurs sooner than later. And this could favor IVF again, because after a laparoscopic clearance, we would give them 6 months to 1 year to get pregnant. And so many patients have no patience. In 2 to 3 months, they come back and say, I've not got pregnant, please do IVF for us. But if you want to give surgery, it's due importance, then one needs to wait for 6 months to 1 year. Nobody has the patience in today's world. They want the baby to crawl out of the bed next day of the surgery. In fact, IVF can even be favored in most cases, considering the current trend to postpone pregnancy seeking into the late 30s when natural fertility is already on a decline. So a lot of patients emerge at 36, 37 when already their fertility is declining, and then they find out that, oh, their AMH is low, they have endometriosis. So let's get pregnant soon. I mean, I have seen patients coming after 2 months of trying with no problem there, but asking that they want to get pregnant soon. They had thought that in the next 3 months they will get pregnant, and this is the third month and she's not got pregnant. So this is now the mindset of people, that whatever they want it within the planned schedule. So we would say that the dogma that endometrioma surgery is the systemic first-line therapeutic option warrants being revisited. This was there in the 1990s and the first decade of 20s, when we all thought, oh, surgery is very important. Even fulgurating the minimal and mild endometriosis is important. But after that, say 15 years ago, there came lots of papers which said that this is not important. Today, as a rule of thumb, surgery for endometrioma before IVF should not be performed unless the patient has pain that interferes with her daily life, or we detect on ultrasound a rapid growth of cyst, or sonographic features of malignancy. These are the two important indications where we have to do surgery first, with or without the ovarian reserve going low. But it is very important to detect a malignancy or cure the pain. Try IVF first should not be a physician's decision, but in most cases, it will be the decision of a properly informed patient. So, even saying try IVF first is not correct in today's world. So, we don't need surgery before going for IVF, but surgery is important if there is intractable pain or we have doubt of diagnosis. And we should not be the ones to say try IVF first. We should open up the options to them and let the patient choose out of that. Having said that, I brought a few slides about impact of adenomyosis on IVF outcome. So what we found was that with endometriosis, it doesn't have an impact on IVF outcome, but yes, it interferes with the process of IVF. It interferes with the safety of IVF because if we don't remove it, there is a risk of forming of abscess in the endometrioma. Adenomyosis, on the other hand, may be a little different. Well, this is a 2021 study, and it is a prospective cohort study of women undergoing 4,002 IVF cycles who had undergone a screening ultrasound assessing features of adenomyosis by the Musa criteria for 1st of January 2016 to 31st March 2018 at a multi-site private fertility clinic. 1,228 fulfilled the inclusion criteria and commenced an IVF cycle with a subset of around 700 women undergoing an embryo transfer. They concluded that women with and without ultrasound features of adenomyosis had no significant differences in most of the IVF outcome, including live birth rates. Now, all those who may have read this article, I'm sure Dr. Tanu has read it. It is it is early adenomyosis. It is not a very severe type of adenomyosis. There are just adenomyotic criteria, three criteria, and you say yes, adenomyosis. They have no impact. But then there have been so many studies in the past which reported no adverse effect, while others showed that poorer outcomes of IVF and increased incidence of miscarriage in infertile patients with adenomyosis. Now, patients, what did they eventually find was patients with greater number of ultrasound features of adenomyosis may have lower clinical pregnancy rate in IVF-ET. And another group is poor pregnancy outcomes were also related to adenomyosis patients with uterine enlargement. So if the uterus is really enlarged or there are greater number of ultrasound features of adenomyosis, then the pregnancy rates go low. So this is another recent study on which one of my fellows is probably working. I don't know, she's taken this pattern, but not exactly this. This is very interesting because here they compared the clinical outcomes of 158 adenomyotic patients enrolled for IVF. Now, they looked at the uterine volume before FET, and they concluded that the cutoff for uterine volume was 98.8 cubic centimeter, which means almost 100 cubic centimeters. Now, grouped by the cutoff value of uterine volume, 83 patients were in group A, which said less than 100 cubic centimeters, and 75 patients in group B, which said more than 100 or 98.8 centimeters. Adenomyosis patients with larger uterine volume above 98.8 prior to FET may suffer lower live birth rate due to higher incidence of miscarriage. So controlling the uterine volume before embarking on FET procedures could be recommended. Now, whether you control it by surgery or by medical therapy, this depends on how the patient responds to therapy. This is a chart given by M. Duham, Best Practice and Research Clinical Obstetrics and Gynecology 2018, which said if there is slight disease, few symptoms, standard ART 2-3 cycles, oocyte retrieval, cryopreservation, and if there are endometrial cysts, treat them, give GnRH agonist for 2-3 months, and then transfer cryopreserved embryos. But if there is moderate or severe disease, that means the uterus is enlarging and enlarging further, oocyte retrieval and cryopreservation for 1 to 6 cycle, and then GnRH agonist for 2 to 6 months, transfer of cryopreserved embryos, and repeat 2-3 times. See, if the patient still doesn't get pregnant and she's less than 40 years with localized disease, you can think of surgery. if she's more than 40 years and diffuse disease, then GnRH for another 3 to 6 months, and then transfer of cryopreserved embryos. So it is very interesting to see the uterine volume. And if we see the uterine volume being more than 100 cubic centimeters, it would be wiser to sort of reduce the uterine volume before transferring. A lot of people said very minimal adenomyosis, and they like to give treatment to reduce adenomyosis. I don't think that is recommended. If there is minimal adenomyosis, and the volume of the uterus is not large, we can go ahead with transfer of our embryos. Like the first study said that with 3 Musa factors, they had no difference in live birth rate in both the groups, with or without the Musa factors. Same way I feel, slight disease, few symptoms, just 3 positive Musa factors, no need to do anything. Just go ahead, do standard ART. But if there's moderate to severe disease, you have to treat them medically or surgically. Having said that, adenomyosis only of substantial volume and size could have detrimental effect on IVF clinical outcomes. It might reduce pregnancy and live birth rates and increases miscarriage rate also. Several studies reported that pre-treatment with gonadotropin releasing hormone agonist before IVF cycle is an effective way to reduce the uterine volume and increase the clinical pregnancy rate of patients in the setting of adenomyosis. And the proponents of medical treatment say that the uterus is not scarred because in surgery, especially if it is, then it, and similarly, in even localized adenomyosis, again, it is a surgical scar in the uterus. So I mean, it is up to you. If you are very good in surgery, maybe surgical treatment is a good option. But after surgical treatment, also, one needs to wait 3 months before an embryo transfer could be done. With GnRH agonist, maybe 3 to 6 months pre-treatment before you get a substantial reduction in size of the uterus. So having said that, thank you very much. Now I want all the well-learned audience of mine to come up with questions and to raise their answers.
So, ma'am, first of all, it was very wonderful and very exhaustive cover topic, and the way you have explained everything to us. Ma'am, I had 1 or 2 questions. First was that, according to you, in your huge clinical practice, what do you think is the most difficult cases, kind of cases that are, to decide whether we should go for the surgery first or go for the IV? Which are the most, I mean, where the decision is really, really difficult?
See, Tejashri, if the age is on the higher side and the ovarian reserve is low and endometrioma is less than 100 cubic centimeters, maybe I'll go for IVF first. But if it is 100 cubic centimeters or more, I'm afraid of, causing
Yeah.
infections. I'm afraid of, it interfering with
So,
my
yeah,
reaching the
advanced age, low AMH, and with a huge endometrioma, you'll still prefer a surgery first.
it is very difficult to say with clarity. Like the guidelines say, oh, doesn't matter, size doesn't matter according to guidelines now.
Correct.
But
Yeah.
but I feel that size, if it is really large and it is interfering with my antral follicles which are distant to it, I would want to remove it, or maybe try and give medical treatment. But that is only in younger patients where I can give 6 months of medical treatment, see that the
And wait for
endometrioma
that long.
reduces in size, and then go ahead. But not in the elderly ones. Khushbu Goyal
Another thing
question.
was,
What is the preferred medical management for adenomyosis mirina or GnRH agonist? Tejashri, you tell, which would you prefer?
I think we would prefer a GnRH agonist depending upon the
Okay.
size of the adenomyosis.
Or
Because if
anyone
it's a very
else?
big uterus,
Yeah.
then Mirena would be difficult to
Big
stay.
uterus again, yes, Khushbu Goyal. In a uterus larger than 3 cubic, the length, if it is more than 10 centimeters, then a Mirena doesn't work over there. Mirena slips out or it has very little effect. A uterus has to be less than 10 centimeters long. Anything more than
In
9,
fact,
also Mirena would not
in
work.
few patients, we have first got down the size of the uterus with
And then,
GnRH agonist and then
yeah,
inserted Mirena.
yeah. Bhavani, you have any comment on this? Anyone else? I want people to speak up.
Ma'am, may I ask? I'm Shalini.
Ah,
Good
Shalini.
evening, ma'am. Yeah.
Yes, Dr. Shalini,
Ma'am,
please.
yeah. Ma'am, what do you give for young adolescent, endometriosis, young girls complaining of pain? I mean, see, she's 18 and 20. There is an endometrioma of, say, 4 centimeter. So do you prefer giving
4 centimeter is really small in today's world. So, a young girl,
she has
adolescent,
pain, ma'am.
pain, you have to see, you have to relieve her pain, whether it is with
Mm-hmm.
GnRH agonist, without letrozole. Someone, as Neera Singh has written, letrozole. I don't give letrozole for a long time, but at least the
Yes.
first 15 days or 1 month, I like to give
Mm-hmm.
so that E2 levels go down faster. But
Mm-hmm.
for young adolescent girls, if she has pain and it is relieved by GnRH agonist or by Dienogest or by any method, I would
So,
prefer the medical method.
Dienogest or ethinyl estradiol plus Dienogest, the 3 days combination.
No, no,
Between
not ethinyl estradiol. Why would I want to give ethinyl estradiol, which causes growth of endometrioma? I somehow don't understand the
yeah,
preparations which have come out of Dienogest with ethinyl estradiol. I think
yeah,
Dienogest is superior to oral contraceptives only because of this, that oral contraceptives have a small amount of ethinyl
estrogens.
estradiol. Once upon a
Yeah.
time, I used to think, oh, OC pills are the best. But the more you
Mm-hmm.
read, you get more clarity. And
Yeah.
I feel Dienogest is a progesterogenic agent. It is better, and GnRH agonist with a little add back after 3 months is very good. What will anyone else do, Hina Khan? In a young adolescent, what would you want to do, Hina, Madhura? I mean, if it is a young adolescence, you can give her these medicines for 4 or 5 years also. You can give her first GnRH agonist, then change over to probably Dienogest, then change over to an continuous OC pill if there's not obesity and no other risk factor for OC pill. So you can keep changing and give her for 6, 7 years. And I have had girls where the endometriosis has disappeared totally.
Yeah, even I have seen endometriosis disappearing in adolescent girls, especially
Yeah.
once given with Dienogest, I have seen, ma'am.
But if the
And
pain goes away, then you don't need to do a surgery. But despite reduction in size, or there is no reduction in size after 3 to 6 months, then it calls for a surgical evaluation and treatment. If the
so
size
Ma'am,
Dienogest,
Dr.
yeah.
Gitika,
yeah,
So, ma'am, Dienogest you
yeah.
prefer giving continuous?
continuous, absolutely
Yeah.
continuous.
Okay,
How
ma'am.
does
Thank you
everyone
so much,
else
ma'am.
give? Anyone else gives it cyclically? I don't somehow think that there's much logic in combining the estrogen with Dienogest and giving it cyclically, because even with Dienogest alone, patients do experience a little menstrual bleed at
Yes,
Few
ma'am. They do
pharmaceutical
get
companies have
spotting off
come
and
up with
on.
yeah,
these OC
Yeah.
pills, sort of a thing with Dienogest as one of the component.
yeah,
Free days, I think, is one of them. So
Free
yeah.
days, and in
people
fact, the buyer company has recently launched this thing, estradiol valerate and Dienogest.
Yeah, you know what will happen?
it
I
doesn't
think
make
one of you
sense.
need to do a study to see Dienogest alone and this, and look at all small symptoms which could come up. And
Yes,
does that
exactly.
menstrual bleed which the patient gets every month gives her a larger psychological benefit? Does it
Mm,
reduce the endometrioma as well as continuous Dienogest? Girls are so
mm,
well educated these days that even if they don't get a good menstrual bleed, and they see on ultrasound the cyst reducing, they are very, very sort of content with that.
Ma'am, we
yes,
have
ma'am.
more questions coming.
Yeah, yeah, come on, come
So,
on.
Dr. Gitika has asked that in new ovarian stimulation protocols, there is use of Dienogest with gonadotropin.
In
And
ovarian
are they
stimulation
helpful?
protocols.
She
Yes,
must be
I'm
asking PPOS, ma'am.
Nahi, yeah, it's
Progesterone
not
primed.
fully Dienogest. I'm not sure that
Mm,
how nicely that would suppress the LH surge. But I can tell you about progesterone, and progesterone could be dufestrone and it could be medroxyprogesterone acetate. That is what I know of. If anyone knows about Dienogest being used in the PPOS program, I would very welcome that
Ma'am,
idea.
and
yeah,
some
Ma'am, I
but
think she
request.
means pre-treatment.
Dienogest,
Pre-treatment for Dienogest.
no, they are using it along
Ah,
with
yeah, a lot of people
gonadotropin.
use pre-treatment of
No,
So
no,
I think
yes, ma'am,
Gitika
they are
wants to
using it.
speak about it. Yeah,
yeah.
They
Gitika.
are giving it as a pre-treatment and they are continuing it with gonadotropins. It prevents, obviously it has progesterogenic effect and prevents premature
Okay. Okay.
surge.
Gitika, we would just
Also,
request you to share evidence on the group
Okay.
If there is
Because,
anything,
Geetika, let me
that
tell
may-
you one thing. If this is COS for a normal patient, not IVF patient, where you cannot segment a cycle, then Dienogest cannot be used. Only in IVF cases, there could be some evidence that Dienogest could suppress that surge and you could continue to use it with COH.
I'm talking about IVF cases only, ma'am. And
Oh,
even Dr. Nalini Mahajan, she was once talking about this protocol, and she is using this protocol in
Ritika,
her.
where are
I
you?
would much
Apna
rather
camera on करो.
welcome evidence rather than giving names of people who are using.
I-
You put
Thank
in an article. I'm so sorry about my cough.
No, ma'am. Take care, ma'am.
It just starts once and I can't stop it. Okay, Geetika, please.
Yes, ma'am, definitely.
Ritika, do share any
No,
evidence that if
yeah.
you have any, studies which are
I just wanted to
good
know your
impact studies.
experience, because only then I would be
We
convinced.
haven't, yeah, we didn't start using it as yet in endometriosis cases, and short-term use of Dienogest with gonadotropin, don't know how much it would be helpful.
No,
We
being started before,
have another question. Okay, yeah,
Mhm.
so down regulation sort of
Too
thing.
much.
Okay, so we have another question. How do you do
Tejasvi,
OQ?
there is an article where they use Dienogest pre-IVF given for 2 months or 3 months, and then they have taken the patients for IVF. But that
Yeah,
is
but
what you
continuing it with
guys saying is
gonadotropin.
continuing, which I've never read, and I
Yeah.
would want an article on this.
Yeah.
Hmm.
So we have next question that in cases of deep endometriosis, where there are dense adhesions, is there a different technique or tweaking of any technique while doing oocyte retrieval?
You tell, Bhavani will tell, someone, my two moderators will answer this question very well. You see, if the ovaries are stuck, it is easier to aspirate them, Madhura. And if they are stuck behind the uterus, then it is difficult because you might have to go through the
might have to go
uterine
through the
musculature. And there the needle gets blocked often. So you have to be very careful that you go in with one single thrust, very quick, get into the ovary, aspirate as many follicles as you can in one go, and then come out. And in case you think you are in the follicle and nothing is coming, believe me, your needle has got blocked because it went through the uterine tissue. And you cannot make multiple punctures in the uterine tissue. Your patient will bleed later on. So these are
Ma'am,
the
where do you advise adenomyomectomy to the patient? That is the next question.
Okay. This is Hina Khan. Hina, tell me, when do you advise adenomyomectomy? You just read, where do you advise adenomyomectomy? You have to be a good surgeon, number one, whether it's open surgery or closed surgery. And you would only advise adenomyomectomy where you feel that medical treatment has not worked or will not work. Then you can do adenomyomectomy. Localized adenomyosis is a better indication for adenomyomectomy rather than diffuse adenomyosis.
Following this, Mayank Jain also wanted to know whether there is, how do we decide the depth of surgery intraoperatively while doing adenomyometry?
See, this is always, you have to leave the endometrial part and you have to leave some serosa. It is like a coring surgery where you can approximate. It's very difficult to approximate the two sides of the uterus in diffuse. I have got stuck in such cases where I had to leave a drain in the inside the incision of the uterus because I felt that the approximation was very difficult. But you do leave the you don't like to open the cavity unless it is opened inadvertently. And I always like to color my cavity with methylene blue, dark methylene blue, so that I know I'm away from the cavity. So you will core the whole adenomyoma. In the serosal side, you will keep a centimeter thickness and then go on coring it and then bring the whole thing together.
Khushbu Goyal wants to know how long can we give Dienogest in adolescents?
Acha, I love this question, Nikita. Nitika, hello, ma'am. Want to ask if we are planning for donor oocyte
Yeah.
IVF with large endometrioma. Is there any benefit of surgery? Yes, if you're taking donor oocytes, absolutely do the surgery for the recipient. she'll be so much better. But it is not an absolute indication before doing embryo transfer. You can leave her alone. You can explain to her if she has no pain, no other symptoms, you can tell her that pregnancy itself in 90% of cases will reduce the endometrioma. So you can leave the endometrioma as it is. Large means how big? 100 cubic centimeters. Huh, Nikita?
You have to unmute yourself, Nitika.
If it is more than 5 centimeter, whether it has any role in the increasing in the fertility?
No, nothing. You can leave the endometrioma and do your embryo transfer. There will be no difference in the fertility of the patient because you've used donor oocytes. So they are coming from a patient who's non-endometriotic, clean. So in any case, even if it was coming from the same patient, it doesn't have an effect. So you don't need to remove the endometrioma from the recipient unless she has pain or the diagnosis is in doubt. That's all. Chaitanya, I loved your question. What will be the time gap we can give in patients with Dienogest? This is what Nitika was saying, that you continue to give Dienogest. I think a time gap is required to stop Dienogest and start IVF. Like with GnRH agonist, no time gap is needed. You give GnRH long-term prolonged use, and while she's on the effect of GnRH agonist long-term, you can start stimulating her for IVF. But with Dienogest, if you want to do a fresh transfer, you have to have the effect of Dienogest gone, her periods come, and then you would start the IVF cycle, Chaitanya. But if you're not looking at fresh transfer, nothing should, nothing should discourage you to start it even earlier.
Yeah.
We have one more.
Is this answer
Yeah.
right?
Sorry to
Chaitanya, does it
interrupt,
look
ma'am.
okay, this answer?
Yes, ma'am. Thank you, ma'am.
If you are not looking at a fresh transfer, then it's okay. But if you're looking at fresh transfer, then you have to have the progesterone effect of Dienogest go away before you start stimulating her. Okay?
Ma'am,
Okay.
so sorry to interrupt, Gitika here. Ma'am, I see a study which was published in 20 Fertile Journal, October 23, and which says, I'll send you the study.
Please.
Says that
Yeah.
this was a
Yeah,
prospective study that, and the Dienogest as a feasible alternative for LH hormone suppression and progesterone primed ovarian stimulation. So
Very
I got
good. So
that,
it
ma'am.
is
I'll send
PPOS.
you
This
the
is what
study.
Tejashree was saying, that
Yes.
it can be used as PPOS instead of using medroxy or dufaston. They've used Dienogest. So
Yes.
good. We got some new
Ma'am,
drug also which can be used.
yes. So, ma'am, can we, if we are suppose there's a patient for endometriosis and we have put her up on Dienogest, and we can continue Dienogest while
Correct.
stimulation?
You
Yes,
can
it
do
will help.
that. You know what, we need to see two things, Nikita, now. One is that you will not do a fresh transfer like after all PPOS
Yes,
protocols.
obviously.
Number two,
Yes.
you will have to see whether she being on Dienogest has not suppressed the LH so much that you would get poor follicular recruitment. You would get poor follicular growth and low E2 levels. इसका एक study निकालो कि those who were on Dienogest 2 months
For a
prior,
prolonged time, yeah, it would
we
be
have had this
there would be a
problem.
lot of LH suppression.
Yes, LH suppression जहाँ बहुत हो जाता है, वहाँ it's very difficult to cause good follicular growth unless you give lot of LH in the cycle. So look at two studies. This is very good. You've told us that Dienogest, if we want to segment our cycles, we can continue to give it as a LH suppressant. But will it lead to if the patient is on long term
Yes,
diet,
ma'am. That needs
then
to
we
be
need to see whether it suppresses
definitely.
so much that it will not cause good follicular growth. ये देख के बताना जरूर, हाँ?
हाँ जी, ma'am. I'll
Put
check.
it in this.
हाँ जी, definitely.
Okay,
There
good.
is one more question, ma'am. 27-year-old infertile female, 5 centimeter endometrioma on the left, and right ovary shows a picture of PCOS with a AFC of 10. So how to proceed?
I missed out on the question.
27-year-old female with 5 centimeter endometrium on the left side and right ovary suggests PCO picture with AFC of 10.
Very good. Just go ahead. If
Yeah,
she's ready
go
for IVF, counsel her and tell her that why do you want the ovarian reserve go low? We can take out your eggs, make your embryos. If you have any symptoms with the endometrioma, we will remove it. Otherwise, we could even transfer your embryos with the same, and your endometrioma would go down or would generally 90% cases shrink during your pregnancy, and that's it. I think
Ma'am, wouldn't you want to give her a try with laparoscopy and let her try naturally after doing a laparoscopic removal
yeah,
of the
that's a
endometrium?
very good idea. That's a very good idea.
Because
Then
she's
don't,
young with a good reserve and we can just remove
and
the
she's
endometrium.
27-year-old. Good.
Yeah.
I'm glad you brought this out. My mind was working in a different direction. I
Yeah,
was
after the debate, probably. Yeah.
नहीं, 27-year-old, good reserve, surgery
Yeah.
is a good option, and natural pregnancy is a very good option.
Right.
So we've had a lot of questions. I'm very glad because of
Yes.
the active participation. I'm so glad.
Ma'am,
Madhura,
one more question. Ma'am, have
Madhura,
you in your clinical?
हाँ, एक minute. Madhura, are you there?
Yes,
Madhura,
ma'am.
yeah, because of your request, I started these master classes. Do you know that?
Thank you so much, ma'am. Yes, ma'am.
So you don't get absent any day from
No,
these.
ma'am, I'm not absent. I'm attending. I look forward to all your lectures, ma'am. And
Okay,
because
Bhavani.
of that, so many of us are getting benefited, ma'am. It's a great initiative by you, ma'am.
Okay, ठीक है. Bhavani, yeah, come out with your question.
Ma'am, I was just asking that in your clinical practice, have you seen any case of ovarian abscess following inadvertent puncture of endometrioma?
Yes, I have seen. And in the earlier days, if I can tell you a classic case, which I should have written as a case report, was that in those days, frozen embryo transfer was a rarity. We used to do all fresh transfers. This is 1990s, the first 10 years of IVF in my practice. There was an endometrioma. I don't know how I went into it or what I did. But in the next cycle, she did not get pregnant in the first cycle. So next cycle, we started again. And I aspirated her follicles and then again went into the endometrioma. When I aspirated, it was all pus. So we sent the pus for culture. We put her on magnets. And still, we had no facilities good for cryopreservation. I did an embryo transfer and she got pregnant and she delivered at 9 months. And we put in two embryos. We must have put in more embryos. I don't remember, but it was a twin pregnancy and she delivered. We just treated the ovarian abscess at that point only. The moment pus came out, we sent it for aerobic, anaerobic culture, put her on Metrogel, put her on Magnex, whatever then was available. I don't remember, but all injectables. And transfer was done also in the same cycle because we had no way of, throwing away the embryos. So that was
One,
one case I remember. Another case I remember where there was a pelvic abscess, endometriosis again, and I opened it through the vagina. I pushed my finger through the vagina and had to take out all the pus, put her on antibiotics, sent her away. And then she comes to me after 4 months with a period of amenorrhea, and I found her pregnant. So, miracles of nature, nobody knows. This patient with
one,
abscess got pregnant. That patient where I drained a pelvic abscess, totally frozen pelvis, comes back after 4-5 months as a 9 weeks pregnancy, a natural pregnancy. So कभी भी endometrioma patient को नहीं बोलना चाहिए you can't get pregnant. You can get pregnant. You continue to try, but if you don't, come back.
so there's one last question, ma'am.
Yeah.
Dr. Shivangi is asking whether we can go for a modified natural cycle embryo transfer in a patient with endometriosis.
Yeah. Why
Of
not?
course, yes. If she has regular cycles, we would prefer doing that.
Yeah, definitely. And you need a modified natural cycle only when you do ultrasound on day 11, 12, when you find no dominant follicle has emerged. You can add a little gonadotropins, but in those who have absolutely pakka regular cycles, there's no harm of waiting till 15, 16 day also for a good follicle to emerge.
Ma'am, many a times endometriosis patients, they say that our pain increases during stimulation. It becomes very severe. So do you feel letrozole can be given in these patients to lower
Why
their
not?
E2? Will it help?
Why not? Why not? Definitely. But I think the pain is not because of high E2 levels. It is because of the stretching of the ovarian capsule due to growing follicles. That is what leads to the pain. But you can try letrozole and see. See, we are all clinicians working on evidence. So it is very important to continue to, use things, find evidence, and continue to use what evidence supports. And we also need to do new innovations because evidence may not be there for everything. But if you do something new, then we should be able to record it.
Ma'am, Dr. Shalini is writing that you must discuss about implantation failure in endometriosis.
I don't know, Shalini, you tell us about how much implantation failure you get in endometriosis. These people have said that
we
miscarriage rate
should
increases.
we
Miscarriage
should be ruling out adenomyoma in the
Yeah.
adenomyotic uterus,
Adenomyosis
and
has
that
implantation
is
failure and high miscarriage
yes.
rate. Correct.
Also, what quality of embryos she's making. If the embryos are poor quality because of the endometriosis, or is she having
Yes.
good embryos? That is a scenario which we have to
Normal
see what
patients,
quality of embryos she's.
yeah, normal patients with unexplained infertility sometimes also have fertilization failure or embryo development failure or have poor quality oocytes. So it is not endometriosis because I think every third patient of ours has endometriosis. If that was so, then all those would not have ever got pregnant. But I don't think endometriosis is imposing so much risk as is thought of.
Thank you so much, ma'am. I think we'll stop here, and we would like to have more questions. If somebody has more questions, we can discuss on the group as well.
Yeah,
Also,
what
if any.
this girl did, Yukti did. I would want all of you who are conscious about what you're doing or you want to find a result of that, put questions and put answers also. तुम लोग सब इतने internet savvy हो, इतने Google savvy हो, you will find answers to all your questions. Yeah, Tejashree?
Yes, ma'am. Thank you so much. Thank you for, ma'am, this, lecture while you were so unwell. And we look forward to more of this. And I would also want our participants to suggest more topics if they want certain specific topics, or else next topic, then we will soon post on the group. Thank you so much.
Thank you.
You, ma'am, get well soon, ma'am, from all of us.
Yeah, thank you. Thank you. Okay, bye-bye. Bye-bye.
Bye.
Thank you so much, Mr. Dave, for helping us to do this Zoom meeting. Thank you very much. I would always wish you to say a word about the assistance you are giving us to conduct these classes.
Thank you, ma'am.